Okay, good evening everyone, and most welcome to this webinar together with Dr. Yasmina Abourfirass and Professor Patrice Yesendi from Brussels. I will have the honor to introduce Professor Yesendi, who will introduce Dr. Abourfirass. But first, most welcome to all of you who have joined tonight to this webinar series of Collective Minds, where we take you through an interesting case from initial findings to a confirmed diagnosis. This is the fourth webinar in the order, and all of the webinars will be available after they completed on Collective Minds, the cases, along with the recorded webinar video session, so you can review on your own afterwards. So with that introduction, most welcome, Professor Yesendi. I'll let you introduce Dr. Abourfirass. Thank you.
Thank you, Frederick. Welcome to all of you guys, and welcome to this new webinar. We are trying to do it on a regular basis, maybe weekly, and to diversify the topics. So tonight we're going to be dealing with a chest case, which will be presented by Yasmina. And I'm glad Yasmina has accepted the challenge, and she will be presenting the case tonight. So Yasmina is one of my residents, and as you may know, thoracic radiology is not my expertise, so it's also challenging for me to help her presenting the case. But I guess we will have fun listening to her. So you have the mic, Yasmina, and I take a social distance so she can remove her mask.
Okay. Yeah. Hello, hi, I'm Yasmina, one of the residents here in Saint-Pierre Hospital in Brussels. And so I'm going to be sharing my screen. Okay. Okay, so I'm going to start off by talking about this case by presenting the patient. So the patient is a 68-year-old male who comes to the hospital complaining of a chronic dry cough. He's been having this cough for a while actually, and it hasn't been going away. He's a heavy smoker. He smokes 1 pack a day for about 45 years. In his medical history, he has a prostate adenocarcinoma treated by prostatectomy. He also has had tuberculosis in the past. He is an HIV patient who's under tritherapy. He's been taking his medication properly, and he has a depression. So the current medication, as I said, is an HIV tritherapy and some anti-cough syrup that hasn't been much help to him. So he presents himself to the pneumologist, who does a pulmonary cardiac auscultation, which comes back perfectly normal. His arterial pressure is also normal, and his oxygen saturation is fine. So nothing really spectacular in the consultation. So then the pulmonologist asks for some blood work and a non-injected chest CT. The blood work also comes back with nothing really worth mentioning, apart from a slightly elevated C-reactive protein. And his CD4 count is a little diminished to 233. So that's about all there is to mention in his blood work. So then he does his chest CT, which I will be showing here.
You already have the viewer open.
Oh, I opened it a million times. Okay. Okay, it's fine. Okay. So I'm going to show you the pulmonary window first, the axial slices. So what we see here is a mass-like solitary lesion located in the left upper lobe. As you can see, the contours are pretty irregular. Superiorly, it looks a little with speculations with this excavated lesion at the superior part, and then downwards, it seems to be branching out inferiorly, but I would consider this as a mass-like lesion that has irregular, not very regular contours. Yeah, I also wanted to show you guys the coronal slices because we can appreciate better the peribronchial thickening. I'm going to show you guys this. So here you can see this peribronchial thickening here. So, we can see that this mass is pretty much not very well delimited. I'm going to show you the mediastinal windows as well, where we find some calcified granulomas, which I would imagine come from his tuberculosis. So there's one here, for example. He also has a calcified lymph node over here, and he has a enlarged lymph node 1.1 centimeters here. Okay, so this is what I have to show you in the CT scan. And so there's no pleural effusion either, or any pericardial effusion. So yeah, so we can maybe go to the first multiple choice question and see what you guys think about this. Okay, so given the clinical history and CT findings, what is the most probable diagnosis? The first one is reactivated tuberculosis. The second is HIV-related opportunistic pneumonia. Third is metastasis from prostate cancer. Fourth is maybe primitive, a new pulmonary neoplasm, primitive one. And the last option would be cryptogenic organizing pneumonia, or if you don't agree with any, none of the above.
Okay.
Okay, so here most people, well, the two highest answers are reactivated tuberculosis and primitive pulmonary neoplasm. I guess a reactivated tuberculosis would make a lot of sense since he has history of tuberculosis. He has an CD4 count that's kind of borderline, it's kind of low, so why not? Primitive pulmonary neoplasm, obviously he's a big smoker, with his context, why not? Nobody said metastasis from prostate cancer. Obviously this isn't, if it were one, it would be a very atypical presentation, but okay. And then, yeah, HIV-related opportunistic, we can't really exclude that. And cryptogenic organizing pneumonia, 10% said that. So yeah, I guess it would be an option as well. Okay, so I have to close this window, right? Okay. So the pneumologist wanted to make sure that it had nothing to do with his prostate cancer. So he ordered a PET PSMA, which is a prostate-specific membrane antigen exam. And it basically, we look at the uptake and see if it might come from a prostate neoplasm. And as you can see here, I'm zooming on the on this image. It's a key image which puts together the CT as well as the uptake of PSMA. And so we see that the uptake is actually not very important, which excludes the possibility of it being prostatic metastasis. A prostatic metastasis would have been way more intense. It wouldn't present itself this way. Okay, so we go to the next multiple choice question. Given the results of the PSMA, what would you suggest as a diagnosis? Actually, no, it's not. Sorry, I'm mixing up the two MCQs. So given all these, the information that we have, what would you suggest to get close to the final diagnosis? So the first option would be a biopsy, and the second would be start corticotherapy and antibiotics as an empiric treatment, and then follow up with the chest CT.
Okay.
Okay, so almost everybody answered biopsy, which makes perfect sense. In this case, we want to know what is going on in there, so we want to go see directly. So actually, the pneumologist decided to start a corticotherapy and antibiotics, and then follow up with a chest CT 3 months later to see how this lesion is evolving. And so I'm going to show you the follow-up CTs by putting, so the first one that I already showed you guys. So this is the first one. And then the second one is the 3-month follow-up after corticotherapy and antibiotics. So this is the lesion. I'm going to just scroll through so you can get a general idea of how this lesion evolved. I'm gonna stop it at about the same level here. Okay. And I will put in the 6 months follow-up after. So, okay, let me explain. So the first image is the first one that I showed you guys. The second one is after corticotherapy 3 months later. And as you can see, the lesion has, regressed significantly after corticotherapy. And so the doctor decides, okay, so this lesion has a good response to the treatment. We're just going to start de-escalating the corticotherapy, because that's how you stop corticotherapy. We can't stop abruptly, so he de-escalates and does another CT, chest CT 6 months later, just to see how things are going. And this is exactly what I'm going to show you. Okay. Okay, so I'm going to try to go on the same level. And as you can see here, 6 months later, we see that the lesion has augmented in volume again. And so here we have the 3 chest CTs, about 3 to 6 months between each one. The first one being corticotherapy treatment, and the last one would be the de-escalation of corticotherapy. So given the evolution under corticotherapy, what would you suggest as a diagnosis this time? So that's, yeah. So I'm just going to read out the multiple choice. In light of the clinical history, imaging results, and evolution of the lesion under corticotherapy, what diagnosis would you suggest? And so I put in the same ones as before. Four possibilities. Yeah.
All right.
Okay, so that's good. So 50% answered cryptogenic organizing pneumonia, and congratulations to those, because that's what it was. For the rest, you might not be wrong, but in this case, this is what we found. So I'm just going to take you to the next. Yeah, I have to stop sharing this, and then I'm going to share this one. Share. Okay, can you see the PowerPoint now? Yeah, okay. I don't know if you can see that. Okay, so so it was actually a cryptogenic organizing pneumonia. So we sent this to pathology. So they actually did a biopsy later on, and the pathologist describes, I'm going to read out the results. So he describes granulation tissue buds in alveoli and alveolar ducts, rich with fibroblasts, blood vessels, lymphocytes, neutrophils, histiocytes, and giant cells. So it's really just a haystack, to have a little reference to the title, of inflammatory cells, and we couldn't really find any infectious agent or anything that would be the needle in the haystack. We just found a bunch of inflammatory cells, and yes, so that was the pathology results. And so I'm going to move to the teaching points. So what is cryptogenic organizing pneumonia? And what are the imaging features that we expect to find if we do look at one? So cryptogenic organizing pneumonia is a form of idiopathic diffuse interstitial lung disease that is believed to be a consequence of alveolar injury of unknown origin and is characterized by the formation of organized buds of granulation tissue obstructing the alveolar lumen and bronchioles. So the imaging features are very variable. They can present themselves in many, many different ways, but there are, I guess, 3 typical patterns that we would find most frequently, I guess, and I have put them here. So the first one would be a multifocal fluctuating parenchymal condensations. When I say fluctuating, we can say migrating lesions. We can, so that would be the first pattern. The second pattern would be an association of alveolar and interstitial opacities. And the third one, which is similar to our case, would be a spiculated or pseudo-neoplastic mass. So here I took 2 images from our case where we can see this pseudo-neoplastic mass that's kind of spiculated. Okay, so there is a rare sign, but it's highly suggestive of cryptogenic organizing pneumonia. It's present in 20% of COP cases, and that would be the reverse halo sign. And I put an image here, bottom right of the screen, which shows a denser outer rim of consolidation around a focal ground glass opacity. So if we do see this, we have to have in the back of our heads cryptogenic organizing pneumonia. Okay, so the second teaching point would be how cryptogenic organizing pneumonia relates with HIV or an immunodeficient status and tuberculosis. So no correlation has ever been demonstrated between an immunodeficient status and organizing pneumonia. And organizing pneumonia actually may be secondary to alveolar epithelial injury due to an unknown insult. Any possible agents could range from viral infections, toxic gases, medications, radiotherapy, connective tissue disorders, anything really that injures the lung. And in our case, we didn't really find any infectious agents, but it might have been the previous area where there was the tuberculosis, and it could have been a potential trigger for the organizing pneumonia. But since we didn't find anything, then we call it cryptogenic. So cryptogenic organizing pneumonia is suggested when all other possible etiologies are excluded. And so both pathology and response to corticotherapy are mostly suggestive of COP. And imaging features alone are not sufficient to make the final diagnosis. So yes, so that was my case. It was a cryptogenic organizing pneumonia. And thank you all for listening. And I'll be taking any questions if you guys have any questions.